First step in most abdominal laparoscopic procedures is insufflation of the intraperitoneal space with carbon dioxide C aqua gas and introduction of the videoscope system. The original and most established technique uses the varus needle, described in Chapter 14. The varus needle can be placed in any quadrant of the abdomen, but is most frequently inserted just below the umbilicus, where a skin incision has been made for the introduction of a large 10-port for the videoscope. General surgeons, however, have been cautious in adopting this technique of blind puncture because their training has emphasized the importance of complete visualization of the anatomy and of the planned action of their surgical instruments.
Accordingly, the open, or Hasson, technique for entering the abdomen under direct vision has become more popular and safer. This technique can be used to enter into any quadrant of the abdomen but is most commonly employed at the central umbilical site FIGURE1. A vertical or transverse skin incision approximately 10 to 12 millimeters in length is made just below, figure 2, or above the umbilicus. The choice of site may be based on the surgeon's preference or the presence of a previous regional incision that may have adhesions. The subcutaneous fat and tissues are bluntly dissected apart using small, narrow finger retractors or a Kelly hemostat. The white linea alba is visualized and grasped on either side with hemostats. The linea alba is elevated with the hemostats, and a vertical 10 millimeters incision is made through the fascia, figure 2. Further dissection with a hemostat will reveal the thickened white peritoneum, which is grasped with a pair of laterally placed hemostats. The peritoneum is elevated and opened cautiously with a scalpel. A dark, empty peritoneal space is seen, and a pair of lateral state sutures is placed, figure 3. These sutures incorporate the peritoneum and linea alba and are later used to secure the Hasson port. The next step is to verify that the intraperitoneal space has been entered freely. The surgeon's fifth finger is inserted, figure 4. This maneuver sizes the hole for the port and allows the surgeon to palpate the region. Usually this space is clear, but occasionally there are some filiomental adhesions that can be swept away. The Hasson port with its blunt, rounded tip obturator is introduced into the abdomen, FIGURE5. The spiral collar is screwed into the fascia so as to provide a snug gas seal, and lateral state sutures are secured to the notches on the collar. The obturator is removed, the CO2 line is attached, and the stopcock is opened. The surgeon sets the rate of CO2 flow in maximum pressure, 15 millimeters Hg. He or she observes the intra-abdominal pressure and the total volume of CO2 infused as the abdomen enlarges and becomes tympanitic. The videoscope is white balanced and focused. The optical end of the instrument is coated with antifog solution. The videoscope is introduced into the port and advanced into the peritoneal space. If an angled optical instrument, typically 30 degrees, is used, it is important for the operator of the videoscope to establish the correct orientation of the optics in the video head. Typically, the optical bevel is downward viewing, 6 o'clock when the fiber optic light cable is vertical, 12 o'clock. The video head is correctly oriented when its cable is positioned at 6 o'clock posteriorly. Rotation of either instrument from these positions will produce a rotated view on the TV monitor. In the presence of omental adhesions or an enlarged falciform ligament, the intraperitoneal space may not be easily entered as the videoscope comes to the end of the Hasson port. If this area is clear to palpation with the surgeon's fifth finger, careful angulation and rotation of the videoscope usually find the right opening. When the opening cannot be found, the port is removed, and a repeat finger palpation is performed before reinsertion of the Hasson port. In extreme cases, when finger palpation cannot find an easy intraperitoneal entrance because of dense adhesions, an alternative site for the Hasson port should be used. The usual alternative sites FIGURE1 err in the 4 quadrants of the abdomen, although the Hasson port can also be placed through the midline linea alba in the epigastric or suprapubic region. A transverse skin incision is made in the subcutaneous fat spread with narrow finger retractors or a Kelly hemostat. The fascia of the external oblique muscle is incised with a scalpel. Further deep dissection is performed through the internal oblique and transversus muscles, whose thin fascia usually does not require incision. The white peritoneum is grasped between hemostats and elevated. A scalpel incises the peritoneum, and a clear entry into the intraperitoneal space is verified by the deep passage of a Kelly hemostat. A pair of lateral state sutures incorporating the peritoneum and fascia is placed. The remainder of this procedure is performed as described for the umbilical site, see figure 5 in chapter downloaded 2. 2,024,000 terms of most 5 millimeters port sites do not require suture closure of the fascia, especially if the port is passed originally in a zigzag or oblique manner through the